My name's Elluru, and the best way to remember my last name, there used to be a little doll, was half elephant, half kangaroo, Elluru. It's called a Wuzzle doll. It's still available on eBay. They weren't very popular. I'm a ears, nose, and throat doctor at Cincinnati Children's Hospital. And I have to say, of all the pleasures and honors I've had in my life to date, this is probably one of the biggest. To be invited by families and patients to speak about a subject gives me just the utmost greatest feeling. So thank you very much. Even my kids, I have two little girls that are 7 and 9, they're usually not interested in what I do. And when I told them about this meeting, they were very excited, and they've emailed me over the last couple of days asking me lots of questions. I told them about the cute kids that were running around here, and they wanted me to email pictures of them. And I said I couldn't do that, but I would invite them next time to this DebRA conference. One qualifier before I start. I know very little about EB involvement of the airway. So, but don't be disappointed. I do practice a lot of airway surgery. Our center at Cincinnati Children's is world-renowned for airway reconstruction. And so I do know a lot about airways, and the reason I don't know a lot about EB and airway is no one knows a lot about this subject. And we're starting to accumulate some information, and I hope to put that together in this talk for you. So please bear with me, and a lot of things that I do say are not evidence-based, but are based on experience to date. And hopefully we can put that experience to date into more of an objective study in the future. So I just have to give you a few tips or knowledge or background on anatomy of the airway before we start this talk, so that the rest of it will make sense to you. And what I'm going to be talking about is the airway as defined from the very tip of the nose down to where the airway splits to go to the right and left lung. And these are defined as the large airways. Looking at it a little closer, you see the nose, nasal passages here, the oral passages here, and we've already covered some of those topics earlier in our talks. What I'll be concentrating is more of the large airway in this area. And what you have here is at the back of the tongue, you have the larynx or the voice box, and we'll be talking about that area in detail. And then below the voice box is an area right here called the subglottis. And why that's important is because it's the narrowest part in the pediatric airway. And so if problems arise, it's either going to be at the level of the vocal folds or at the level of the subglottis. And the rest of this airway is called the trachea, and where it splits to go to the right and left lung is called the carina. So just a few words of terminology here, and I hope that makes sense. So cartoons are nice, but real live pictures are better, and I hope this projects well. It looks a little light from this direction, but I've given you the correlation over here with the cartoon and what these pictures look like in a real child. So if you come down, if you put a camera down the airway to about this level right here, and you look at these structures, this is what you see. This is the voice box or the larynx, and what you see is this big flap of tissue called the epiglottis. If you zoom in a little closer, you see the vocal folds, and the vocal folds on a normal airway, on a child with a normal airway, looks pristine, crisp, white, and with nice smooth edges. Below the level of the vocal folds is the subglottis that I was talking about, the narrowest portion in the pediatric airway, and that's right here. And then if you go a little further in, you see the trachea. And the corresponding cartoons are over here. So what does this look like when you actually do it in real time? And I'm just going to have you start that video, please. So this is us coming down to the larynx, past the tongue. and you see the epiglottis, the vocal folds, and you can see how nice and crisp and white and smooth they are. And then you can pass the scope through the vocal folds. And this is the subglottis, the narrowest portion in the pediatric airway. And then you go a little further. This is all trachea, and these are tracheal cartilage rings. And then you can see where the trachea splits to go to the right and left lung. So what I wanted to show you today are some of the lesions that we've seen in the airway in different kids with epidermolysis bullosa. But prior to that, I just wanted to take one word or one moment to talk about intubation for surgery. Dr. Wickkugel presented a very nice talk yesterday on anesthesia, and he mentioned some of these topics, but I just wanted to emphasize that point one more time. So when you perform an operation and you have a child sedated, you need to support the airway. So you need to have some way of ventilating the child. There's a mask that you can place on the child's face to ventilate. You can also use a laryngeal mask anesthesia. That is a little mask that goes down to about the level of the larynx. Or you can actually put a breathing tube in that goes through the vocal folds. So the breathing tube will either come in through the mouth, into the vocal folds, and into the trachea, or through the nose, through the vocal folds, and into the trachea. And in children in general, whether they have epidermolysis bullosa or not, the areas of injury that we see are at the nose, at the very tip of the nose, and more commonly at the level of the vocal folds and subglottis. And this is usually thought to be secondary to the trauma of intubation, so just the frictional forces of putting an endotracheal tube through the vocal cords. Not all kids respond adversely to that. Kids without epidermolysis bullosa, most of them will have an uneventful intubation, but if kids are intubated for prolonged periods of time, which some, for example, kids who have extreme prematurity who need to be on a ventilator for a long period of time, they do have a breathing tube in for weeks to months. When this happens, a lot of the injury we see is down here at this level of vocal cords and subglottis. And the type of injury we see is ulceration, eventually leading to scar deposition, leading to narrowing of the airway. So in kids that have epidermolysis bullosa, what can I offer? And once again, this is not evidence-based, but just from experience, is to use the same standards of care that Dr. Wickkugel mentioned. And that's to have an experienced anesthesiologist to perform the intubation when absolutely needed, and to use the appropriate equipment and size tubes, and to minimize trauma when intubating. So what are some of the symptoms that we have when a child has a compromised airway? So what kind of symptoms do we see when we think that the airway is narrowed or there's ulcerations or lesions on the airway? The most common is a hoarse quality to the voice. And I think some of the parents here can appreciate that. But that is a very subtle symptom. It doesn't mean that there's something terrible going on. A lot of us have hoarse voices, sometimes during allergy seasons, or if you've noticed that sometimes if you have any family members who smoke, they tend to have a hoarse voice. It's because of the irritation of the vocal folds. But it is an early and subtle sign of airway involvement. The more significant signs are getting winded. So if your child is playing with the other kids and you see them having to sit down sooner than some of the other kids, can't run as far or play as hard, sometimes that's an early sign too that there may be some airway involvement. That's a hard symptom to dissect because it can also mean that your child may just be not in the same kind of condition as some of these other kids who are exercising on a regular basis. Noisy breathing is another sign, or symptom rather, of airway involvement, and this is usually a high-pitched inspiratory sound. So inspiratory meaning when the child breathes in, you hear kind of a loud-pitched sound. It's like a that's involvement of the airway. Belly breathing or retractions are another sign. When the child is breathing, you see the belly getting sucked in pretty significantly, or more than other kids is a sign. Nasal flaring, so when the child is breathing hard, you see the nostrils flare in and out. And also in these kids, as the airway gets compromised, they also have feeding difficulties, choking on secretions, not eating as much, getting winded when they eat or feed on a bottle. Those are all can be signs of airway involvement. So with the next couple of slides, what I'd like to show you is some of the airway lesions that we've seen in kids with epidermolysis bullosa. The EB simplex kids, we haven't seen very much airway involvement, and the kids that we have seen airway involvement are more the dystrophic kids and the junctional kids, and so those are examples of what I'll be showing you. This is a child with dystrophic EB, and hopefully the anatomy will make a little sense to you, but the first picture was at the level of the larynx. You saw the epiglottis, and then we'll loop through this one more time. And as you get through the vocal folds, the airway at the level of the vocal cords is a little narrowed, but as soon as you get past it, things open up quite a bit. This is going back once again to the very front where you saw the epiglottis and airway involvement. Let me move on to the next slide because it shows another slide. This child, because of the airway involvement, you can see the lesions up here. We had to put a tracheostomy tube in this child because we were concerned and this child was getting fairly symptomatic. And this is after we had put the tracheostomy tube in, going through the vocal folds, and you can see the tracheostomy tube coming into the airway anteriorly. This was the airway involvement with the epiglottis having some of these ulcers. What was interesting about this child is we did do periodic endoscopies to evaluate the airway before the tracheostomy tube went in, after the tracheostomy tube went in, and at several intervals after that. And what we noticed was this is the epiglottis, and that's that flap of tissue that sits above the larynx, and you can see the ulceration. And hopefully you can remember what the normal epiglottis looked like. It looked more thin and crisp like this. So this is the first time we saw the child. The second time we saw the child after we put the tracheostomy tube in, a little further down the road, and then finally with the latest endoscopy. One of the things that you see is that the amount of ulceration has decreased in these pictures progressively. And this child is fairly asymptomatic. In fact, they cap their tracheostomy tube, meaning they put a plug over the tracheostomy tube so they're not using it, they're actually breathing through their nose and mouth. But one of the, and they're doing fairly well. They have some intermittent episodes of airway obstruction, airway symptoms, but it's not terrible. And one of the things that we introduced very early on into the therapy for this child at this point was reflux medication. So going back to my experience and our experience as a center with some of these airway kids, we know that reflux disease can cause the larynx to be inflamed. It can cause kids to cough. It can cause the larynx to be irritated. And so putting these kids with epidermolysis bullosa on reflux medication, and specifically this child on reflux medication, seemed to be appropriate. And the child seems to have responded to the reflux medication with less ulceration and less inflammation in the epiglottis. And so that's led, and this is once again anecdotal, this is not evidence-based research, but it does seem to make sense that in our airway kids that don't have epidermolysis bullosa, treating the reflux disease helps the larynx. So why not in kids with epidermolysis bullosa as well? And this is one of the only variables we changed in this kid, and this kid has looked and done better. So we have started treating a lot or most of our children who have airway involvement or symptoms or signs of airway involvement with reflux disease. And as some of the speakers have also mentioned, reflux medications are not without their side effects. So as you entertain this treatment option with your physicians, you want to look at the risks and benefits. And I think some of the risks have already been discussed in Dr. Farrell's talk yesterday, so I won't talk about those. But it's all a risk-benefit calculation. And the type of reflux medications that we do use are Zantac, which is a histamine blocker, a H2 blocker, and it blocks the pathway to acid secretion. It's in the spectrum of efficacy, Zantac is probably a mild drug. Proton pump inhibitors are what I put most of these kids on because it goes in right to the machine that makes the acid and stops it, so it's a lot more efficacious. There are some conservative measures you can use as well that are not medications. You can use things that make sense, such as drinking plenty of water, not having afternoon or late night meals, decreasing caffeinated beverages, and also late night spicy food. Things like that can be more conservative if your child has minimal disease and you're worried about reflux. All right, so I'm going to move on to some of the lesions that we've seen in junctional epidermolysis bullosa. And these lesions can be quite more significant. We've seen everything from floppiness of the larynx, and this is an example of such a child. So this is looking at the larynx, the flap-like structure, which is called the epiglottis. The vocal folds are down here in this little hole. But in some of these kids with junctional epidermolysis bullosa, we've seen a floppiness of the back part of the larynx. And what happens in these kids is they do have respiratory symptoms. They have shortness of breath, noisy breathing, and it's because the floppy back side of the larynx caves into the airway when they breathe in. It happens in all kids, whether they have epidermolysis bullosa or not. If it happens in kids without epidermolysis bullosa, we have no problems cutting out this redundant tissue. We don't think about it twice, and these kids do great. We've been resistant as a profession to be too invasive on kids with EB because we're worried about excessive scarring and creating more ulceration. But we did a study looking at about a dozen patients that we did intervene with minor surgical procedures. So trimming a little bit of this redundant mucosa or taking out a piece of granulation tissue. Once again, being very delicate to minimize trauma, using instruments that minimize collateral damage. And it seems to work. We don't seem to cause more problems. We seem to alleviate the symptoms when done fairly conservatively and with care, that we can take care of the problem and not cause more. And if you can take away the shortness of breath, the inspiratory stridor with these small conservative procedures, the child benefits significantly, and we haven't caused any harm. So it's in our paper that we published on this subject, we suggested that it is a reasonable option to consider surgical intervention, but small, minimally aggressive surgical maneuvers. This is not always the case. This is another child with junctional epidermolysis bullosa. And this is a hard larynx to make sense of, but that's the epiglottis. Vocal cords we're coming down to in a second. But you can see how distorted things are. Those are the vocal folds, hard to make sense of, a lot of swelling, a lot of granulation tissue. And as soon as you get through the vocal folds, everything looks pristine and normal. This child, when I first saw the baby, had a lot of respiratory symptoms, and we were in discussions with the family on what to do. I couldn't leave the child without some airway support, and we did put in a breathing tube, an endotracheal tube, while the decisions were made. And on this next slide is after we did put a tracheostomy in this child, and we took a look at the airway. And this time, it's almost impossible to make sense of the larynx. It's all very scarred down. Lots of granulation tissue. This is a picture into the esophagus, and you can see some of the granulation tissue and scar tissue there. So I show this because, once again, we don't have all the answers, but I know based on experience with other kids without EB and my minimal experience with these kids, you just have to be minimally traumatic to the airway, whether you're doing any interventions or whether you're putting in a breathing tube, taking out that breathing tube. All has to be done very, very delicately. And sometimes it's impossible to stop the process. This child did have a tracheostomy tube placed, and so even though the larynx and voice box is distorted, the airway was supported. Brings up the last question, or the last point, tracheotomies, and what is the role of a tracheotomy or an ostomy in kids with epidermolysis bullosa. This is quite controversial, and I think it's a very individualized decision that you have to make in conjunction with your epidermolysis bullosa team, and discuss all the pros and cons. And we've had some great successes. The first child, or the movies I showed you on the child with dystrophic EB that we put a trach in, the family was very, very hesitant to put the tracheostomy tube in, and we discussed it at length, and we finally did proceed with it. And now we talk about the options of taking it out, and the family does not want to. They've been so comfortable with this that they don't want to. I'm not saying that's the right answer for every little child, but it's something that needs a lot of thought, a lot of discussion, a lot of soul searching with you and your doctor. Essentially, the procedure consists of making a hole through the skin, separating the muscles in the anterior neck, and making a hole through the trachea. And so essentially, you're making a pathway from the front of the skin into the trachea. And the tracheostomy tube then will fit into the trachea. And if you have obstruction at this level, you can see how this pathway now bypasses the obstruction and gives the child a secure airway. There's a lot of tracheostomy tubes out there, and a lot of companies that sell it. But in general, if you take all these tracheostomy tubes, you can divide them up into several different types of categories. They differ on side length and curvature. They differ in composition. Some of these trachs have cuffed and non-cuffed tubes. Some of them have fenestrations and non-fenestrations, and some of them have intercannulas. And I'll talk about all of these real quick. So the size, length, and curvature makes sense. Not every baby's the same, not every neck is the same, and so we have different size endotracheal tubes that will fit appropriately fit the diameter of the trachea. And you can have different curves on these so that the tracheostomy tube fits nicely in the middle of the trachea. The tracheostomy tubes change in composition. For a long time we used metal tracheostomy tubes, and in some third world countries they still use metal tracheostomy tubes. But these are fairly caustic to the body, so we tend to stay away from them. The benefit why people use them is they're fairly inexpensive because you can clean them and reuse them forever. We tend to use a lot more of the silicone and polyvinyl chloride and tracheostomy tubes these days. The cuffed endotracheal tubes, really not needed in most kids with epidermolysis bullosa, but these are needed in kids with who are on the ventilator for prolonged periods of time. And what the cuff does is essentially seals the space between the trachea and the tracheostomy tube, so there's no air leakage, so the ventilator can work efficiently. And so most kids don't need the cuffed endotracheal tubes unless they're on a ventilator. The fenestrated endotracheal tubes essentially have a small hole, not only at the distal tip to breathe through, but they also have one here. And what that allows is air to come out when you breathe out, for air to not only come around the tracheostomy tube, but also through the tube itself, up through the vocal cords. And why that's important is because it allows kids to vocalize. So you need that air to come up through the vocal cords to vocalize. Some tracheostomy tubes have inner cannulas, and this allows the inner part of the tracheostomy tube to be cleaned out. The downside of this, and we don't use this very much in kids because the inner cannula takes up a lot of space and decreases the diameter and the breathing space for the tracheostomy tube, which is already small for little kids. The other important thing to know about tracheostomy tubes, and this is a question that a lot of families have, is can my child interact and talk with us after we put in a tracheostomy tube? Yes, and one of the ways that we facilitate that is with the Passy Muir valve. And it's just named after the people who invented it, but it's a one-way valve. And so what this allows is air to come into the tracheostomy tube when the child takes a breath, but when you breathe out, that valve blocks the air from coming out of the tube so that it's forced up around the tracheostomy tube and up through the vocal cords. So air comes in, and then air comes, when you breathe out, goes through those vocal folds and out, so the child can phonate. And most kids with epidermolysis bullosa who have a tracheostomy tube in place are candidates for this Passy Muir valve. So putting in a tracheostomy tube does not guarantee that the voice will be gone. There are some other advantages to the Passy Muir valve as well. Improves swallowing, it reduces the need for suction because kids can cough out the secretions. Tracheostomy tubes, and these are some of the downsides of tracheostomy tubes, so, but I need to mention them. The tracheostomy tube definitely does change the physiology of breathing, because now air going through the tracheostomy tube does not go through the nose to the lungs, but instead just to the tracheostomy tube to the lungs. So the smell is taken away, the humidification of air is taken away, there's no filtration mechanism, there's no warming mechanism for the air. And it can change the swallow. There are some complications of tracheostomy tubes that you have to know about too, and the most important one in these kids with epidermolysis bullosa is you can have skin breakdown. So the way these tracheostomy tubes are secured is with a strap around the neck. This obviously causes a bit of friction to the skin, and so the skin breaks down. What we've done at our center is to use Mepalax, different thicknesses around the stoma site, around the trach ties around the neck, and this has helped. But it does add to the kind of care and the amount of care that these kids need. You can have trach plugging, so these kids need to be suctioned fairly frequently if they're not coughing it out themselves. The trach tube can come out, which is a dangerous situation, and so if it does come out, it has to be replaced immediately, and the parents at our centers are trained how to do this and given some alternative ways to also replace the tracheostomy tube if it gets dislodged. You can get some granulation tissue around the distal tip. This is an area of friction, and another area of friction up here, so you can develop some granulation tissue. And some of the other complications are suction catheter trauma. When you're suctioning out these kids, if the catheter goes too far into the airway, you can traumatize the airway. You can get some deformities of the trachea, secondary to the tracheostomy tube being in, and some other things such as aspiration and bleeding, which are fairly minor. At our center, when we do send home a child with a tracheostomy tube, we make sure that the parents are very, very well educated. They actually have to go through a course and pass certain tests and be checked up on all of these things. And it involves all of these different aspects, suctioning the trachea, changing the tracheostomy tube, skin care, what to do in case of emergencies. And we also try to get the family as much help as possible with home health care, getting the child integrated into school so that they're not being refused school participation just because of a tracheostomy tube. And also set them up with the necessary equipment and the vendors to get more. And then we also instruct the families what to carry around with them if they do go outside the house. Don't want to show too many scary pictures of tracheostomy tubes, so I'm going to stop there. Once again, tracheostomy tubes are an option, but once again, has to be balanced against everything else that's going on in the child's life, family life, and requires some intimate discussions with your physician and your physician group. These are a couple of resources about tracheostomy, including Erin's tracheostomy page, which is a family-run portal, and my email address at the bottom, and then the website for our division. I'd be happy to take any questions. Sure.
My son has recessive dystrophic, he's 15, and I've actually never heard of children with recessive dystrophic. I never heard of children with recessive dystrophic needing a Trach. So how often, what's the incidence of that?
Yeah. And we're starting, this is all very anecdotal, once again, just based on what our team has seen. I don't have to go down to the EB clinics very much, which means that there's not a lot of kids who are coming in with airway involvement. It's fairly rare in general. And with the dystrophic, it seems to be a lot less than the junctional. The junctional kids seem to have the most airway involvement, but the dystrophic kids, I would say, mild, minimal percentage.
Love to be able to give us more time for questions, but we're due for a break now. So thank you so much.
Thank you.